Welcome back to the deep dive. Today, we are taking on a really deep dive into the architecture of life support,
We are.
specifically the kidneys. I want you to just try and picture the most, I don't know, sophisticated water treatment plant you can imagine.
Right, but one that fits in your hand.
Exactly. It's compact, it runs 2047, and it's managing your entire internal chemical balance. I mean, it filters something like 180 liters of fluid every single day.
The precision is just staggering. The decisions it makes on a micro level, what stays, what goes.
And when that system fails, it just sends these shock waves through the entire body.
It really is the ultimate metabolic regulator. The language of renal failure, the symptoms, the clues you see under a microscope, it's basically the body screaming that its foundational balance is gone.
So if you can read those signs, you get this immediate access to understanding some of the most complex systemic diseases out there.
You really do.
And the source material we have today is, it's pretty remarkable. It's not just some casual overview.
No, this is a masterclass.
It's a masterclass designed by an expert surgical educator. It moves so systematically from the most fundamental things, like the tiny protein casts and crystals you see under a microscope, all the way up to, chronic autoimmune disasters and major cancers.
And our mission today is really to transform this huge volume of data into something clear, structured, and hopefully memorable for you.
We're going to focus on the core concepts, the visual markers that really stick in your head.
The aha moments of diagnosis.
Exactly. And the clinical why behind them. We're trying to give you a shortcut to mastering the visual language of nephrology.
And we should probably start with the architect behind this whole curriculum.
Yes. Before we jump into filtration mechanisms, we have to acknowledge that the clarity of the structure is, in itself, a huge part of the learning process. It's all inspired by a very specific teaching philosophy.
It is.
Let's unpack the credentials and the philosophy of the source author, Dr. Senthil Kumaran. We are basing this deep dive on his work, and I think his background explains why this material is just so rigorously organized.
Well, his pedigree is immediately obvious, and it's important for understanding the quality here. He got his MBBS from Jitmer Paducherry and his MS from PGMR Chandigarh.
And these aren't just good universities, right?
Oh, no. These represent, the absolute pinnacle of medical training and clinical rigor in India. They demand excellence in your foundational knowledge, even for surgeons.
Right. And he's channeling all of that deep training into his current role as an associate professor in general surgery at IIM's Nagpur. So we're talking about an expert with, over 15 years of post-MS experience?
Yeah, and that longevity means his knowledge isn't just from books. It's this sophisticated blend of teaching, active clinical practice, and ongoing research. He sees these diseases from the slide all the way to the surgical table.
That's such a crucial point. He's a surgeon focused on intervention.
Right, but he recognizes that a good intervention, a successful one, relies on absolute certainty in the pathology. His dedication to teaching this stuff highlights his belief that diagnosis is always the essential first step.
And that brings us to his core teaching philosophy, which really structures this whole masterclass. He specifically acknowledges his mentor, a Mr. Nilesh Lodhaji, sir. What does that tell us?
It tells us everything. It's the key to the delivery system. He credits this mentorship for guiding him on, and this is a quote, innovative memory techniques and student-centric animation-based learning methods.
Okay, so that's crucial. This isn't just an arbitrary dump of facts.
Not at all. The material is meticulously engineered to be retained, to stick with you, especially when you're under the pressure of clinical practice or, a big exam.
So we shouldn't expect dry academic text. We should be looking for these vivid visual frameworks, these really specific associations.
Precisely. His goal is to avoid that classic information overload you get from heavy pathology textbooks. For example, when we discuss a disease, we're not just going to name a deposit. We're going to use the specific visual descriptor.
Like the coffin lid crystal shape.
Or the spike and dome pattern, the tram track. Because those visual cues are the memory hooks. They make a complex, abstract concept concrete and, more importantly, recallable.
We're basically following a syllabus that's designed for maximum retention.
That's the idea.
That context is vital. Knowing we're following a guide that's been optimized for learning means we can trust the structure. So let's adopt that structure right now and move straight into the fundamental clues the kidney gives us.
Okay, so to start diagnosing kidney disease, we have to look at the output. The kidney gives us these essential signals both in the urine it excretes and, if we need to look deeper, in the architecture of the tissue itself.
And we start with urine microscopy. I think the most telling signs are casts. These are what, microscopic molds? Cylinders formed in the tubules of the kidney.
That's a great way to put it. They're shaped exactly like the tube they were formed in. They're primarily formed from this protein called Tam horsefall protein.
Which is secreted by the tubular cells.
Right. But what makes them diagnostic is what gets incorporated into that protein matrix. The type of cast gives you an immediate, localized view of the severity and the location of the damage.
Okay, so let's start with the baseline, the non-alarming ones.
That would be the hyaline casts.
Hmm.
These are the most basic type, just protein, and they aren't necessarily a bad sign. You can see them in perfectly healthy people, especially after, say, strenuous exercise, dehydration, or a fever.
So they just represent normal protein secretion, more or less.
More or less.
But then we get to the serious red flags, starting with the clearest sign that the glomerulus, the filter itself, is completely compromised.
That's the RBC cast, the red blood cell cast. Finding this is a critical moment in diagnosis. It means that intact red blood cells have leaked through a damaged glomerular barrier, traveled down the nephron, and gotten trapped and molded in the tubule.
So it's basically the pathognomonic sign of active glomerulonephritis.
Absolutely. It confirms the bleeding is coming from the kidney itself, not from the bladder or the urethra somewhere downstream.
Okay, so if red cell casts point to the filter, what about inflammation that's localized to the plumbing below the filter?
For that, you look for WBC casts, white blood cell casts. These tell you the inflammation is happening after the initial filtration, deep within the tubules or the surrounding interstitial tissue.
So that points to things like a kidney infection.
Exactly. It strongly suggests a severe local process like acute pyelonephritis, which is an infection of the kidney parenchyma, or interstitial nephritis. If you see this, you know the problem is the kidney tissue itself, not necessarily a primary glomerular disease.
And then the cast that just screams acute tubular necrosis, the one with that very evocative name.
The granular muddy brown casts. This is maybe the most critical visual clue for acute kidney injury. They get that color and consistency from necrotic, slewed-off tubular cells and debris clumping together.
So seeing these is an immediate high alert signal.
It's an almost immediate sign of acute tubular necrosis, ATN, often caused by ischemia or toxins. It signifies a sudden, massive death of the functional cells in the tubules. That muddy brown image is the one the masterclass really wants you to remember for acute failure.
And finally, what about the cast that signals a massive protein leak and lipid issues?
That would be the fatty casts. These show up because of significant lipiduria, which is secondary to heavy protein loss. In nephrotic syndrome, the liver kind of overcompensates for lost albumin by pumping out more lipoproteins, which then spill into the urine.
So these are strongly linked to nephrotic syndrome.
Very strongly. Sometimes they even show a characteristic Maltese cross pattern under polarized light because of the cholesterol. It's a really cool visual.
It's just amazing that failing body systems can produce these perfectly rigid geometric forms. The crystals in urine are like a puzzle where the shape gives you the answer.
The visual details are everything. For instance, uric acid crystals are often just described as pleomorphic.
Meaning they have varied shapes.
Right, they can look like barrels or plates or rosettes. They're pretty common in concentrated acidic urine.
And what about the classic image for kidney stones?
That would be calcium oxalate crystals. These are highly recognizable. They classically appear as these distinctive envelope shapes, perfect octahedrons, or sometimes as little dumbbells. Seeing them often indicates a tendency for stone formation.
Now for the most memorable one, the one that conjures a very specific image.
The triple phosphate crystal. You never, ever forget this shape once you've learned it. The coffin lid-shaped appearance.
Wow.
Yeah. They're commonly found in alkaline urine, and they're often associated with UTIs caused by urea-splitting bacteria like Proteus. That macabre visual association just makes the identification instantaneous.
And there's one that indicates a rare genetic disorder, right?
Yes, the cystine crystals. These are pathognomonic for a condition called cystinuria. They are rare, but they have this very specific and dramatic hexagonal geometry.
Six-sided plates.
Perfect six-sided plates. Identifying this crystal is critical because it confirms a serious inherited metabolic disorder that leads to kidney stones.
So we've covered the output. Let's pivot now to the filter itself, the glomerular filtration barrier. It's this multi-layered masterpiece that decides what stays in the blood and what becomes urine.
And this is the core architectural principle of kidney health. It's made of three crucial layers in sequence. The first is the fenestrated endothelium.
The capillary lining.
Right, the specialized lining. These fenestrations, or pores, let almost everything smaller than a red blood cell pass through water. Salutes small proteins.
And that takes us immediately to the central scaffolding.
The glomerular basement membrane, or GBM, this is the main structural part, a dense matrix made of type 4V collagen, laminin, and something called heparan sulfate proteoglycans, or HSPG.
This provides the main size restriction.
Exactly. But maybe even more critically, it's where this massive concentration of negative charge is.
And then the final, most complex layer that wraps everything up.
The podocyte foot processes. These are epithelial cells with these long, kind of octopus-like extensions that wrap around the capillaries. The tiny gaps between them are called the slit diaphragms.
Which contain that crucial protein, nephrin.
Right, and nephrin acts as the final gatekeeper, maintaining the integrity of the whole structure.
So those 3 layers enforce 2 absolute rules of filtration. Let's just reiterate those.
Absolutely. Rule 1, size restriction. Anything bigger than 3 to 4 nanometers, like most large plasma proteins, is generally blocked.
And rule 2.
Charge restriction. And this is the subtle genius of the system. The entire surface, from the GBM to the podocytes, is coated with negatively charged molecules, like those HSPGs.
And albumin, the main protein we worry about, is also negatively charged.
Exactly. So it gets powerfully repelled, even if it's technically small enough to slip through the physical pores.
So when we see massive albumin loss, it's not always a gaping hole in the filter. It could just be that the negative charge shield has been destroyed.
That's often exactly what's happening. The albumin can just drift right across.
So understanding this architecture means understanding how to diagnose its failure. The source material is very clear. A complete diagnosis of glomerular disease requires a multimodal approach.
Yes, you have to use all 3 specialized methods.
Which means we start with the big picture, the structural view.
Light microscopy, LM. This gives you the overall architecture, cellularity, scarring, proliferation, any thickening of the membrane. It tells you where the damage is and how bad the structural remodeling is.
Okay, next up is the chemical attack profile.
Immunofluorescence, IF. This is essential for visualizing the what and the where of any immune complex or antibody deposition. Are we seeing IgG, IgA complement, and what's the pattern? Is it linear, granular, or just in the mesangium?
This is how you distinguish between a direct antibody attack, like in good pastures, and immune complex deposition, like in post-strep GN.
As I say.
And finally, to confirm that subtle damage to the foot processes we just talked about.
For that, you need the ultra-high magnification of electron microscopy, EM. You absolutely need EM to confirm those subtle but definitive findings. The subepithelial humps, the effacement of podocyte foot processes, or the characteristic changes in the GBM itself.
Like the thickening or fragmentation you see in Alport syndrome.
Right. So LM, IF, and EM together. That's what paints the whole definitive diagnostic picture.
Okay, using that framework, let's move into the 2 macro syndromes that define glomerular failure. They're often discussed as opposites: nephritic syndrome, which is inflammation, and nephrotic syndrome, which is leakage.
And that contrast is foundational. Nephritic syndrome is about damage to the capillary walls, leading to inflammation and hemorrhage. Nephrotic is primarily about losing that charge barrier, leading to massive protein leakage.
Let's define the nephritic crisis first. It's characterized by blood loss and a rapid decline in kidney function because of active inflammation. What are the core clinical features?
The defining criteria usually start as a triad, but can expand to a penta of findings. First, and most crucially, hematuria. Patients often describe it as cola-colored or smoky urine.
Indicating processed blood.
Yes. Then mild to moderate proteinuria, usually less than 3.5 grams a day. Because the inflammation damages the vessels, the kidney reacts by holding on to fluid, which leads to hypertension and often oliguria or decreased urine output.
And the diagnostic proof.
The presence of those specific red cell casts we talked about, that confirms the source of the bleeding, is in fact the glomerulus.
All right, let's start with the classic delayed reaction. Post-streptococcal GN. This disease is a perfect example of how an infection far away in the body can trigger massive kidney inflammation.
It's the textbook example of immune complex deposition. And the timeline is highly specific. It typically follows a group A strep infection of the throat or skin by about 1 to 4 weeks.
So the body generates antibodies against the strep, and those immune complexes get trapped in the kidney filter.
Exactly. And pathologically, on light microscopy, LM, you see this hallmark hypercellularity. The glomeruli are just packed with inflammatory cells. But the real defining feature is on electron microscopy, EM.
Which is?
The presence of subepithelial humps. These are the immune complexes deposited on the outside or epithelial side of the GBM. This location is key. The immunofluorescence, IF, then shows a granular or lumpy, bumpy deposition pattern of IgG and C3.
And there's a crucial lab test detail here,
A
right?
very crucial one. The C3 complement component is typically low because it's being actively consumed during this massive immune reaction.
Okay, next, let's look at the most common glomerulonephritis worldwide. IgA nephropathy, also known as Buerger's disease. Its clinical timing is almost the opposite of post-strep.
That is a critical distinction for any clinician. IgA nephropathy is unique because the hematuria is often recurrent and synpharyngetic,
Meaning it happens immediately after a respiratory infection.
or very shortly after an upper respiratory tract infection or even a GI upset. It's thought to be due to an abnormally glycosylated IgA molecule the body attacks. And the signature microscopic finding is on IF, massive mesangial IgA deposition. The immune complexes pile up in the supporting stalk of the glomerulus.
And finally, for the nephritic conditions, the genetic one that attacks the structural collagen and brings a triad of symptoms from outside the kidney.
Alport syndrome. This is a disease of faulty scaffolding. It's X-linked in most cases, caused by a mutation in the genes for type 5 collagen.
And since type 5 collagen is in all basement
The
membranes,
resulting clinical picture is a distinctive triad. You get progressive nephritis, often leading to end-stage renal disease, accompanied by high-frequency hearing loss, and various characteristic ocular defects like lenticanus.
and the diagnostic key.
It's the EM finding. The GVM looks fragmented, laminated, irregular. It's described vividly as the basket weave appearance.
RPGN, or rapidly progressive GN. This sounds like the urgent, severe end of the nephritic spectrum.
It is. It implies such rapid destructive injury that renal failure is imminent, often within weeks or even days. The core destructive lesion here is the crescent.
What exactly is a crescent?
It's formed when the glomerular capillary wall is so badly damaged that inflammatory cells, proteins, and fibrin leak out into the Bowman space. This causes the cells lining the Bowman's capsule to proliferate rapidly, along with macrophages, forming this semilunar mass, the crescent, that actively crushes the glomerulus.
And the masterclass organizes this into 3 types, based entirely on the immunofluorescence pattern.
Yes, which tells you the mechanism of attack. It's a perfect example of structured learning. Type I RPGN is anti-GBM disease, which we know as Goodpasture syndrome. The IF pattern here is a striking linear deposition. The antibodies are binding uniformly along the entire GBM.
Like a perfectly straight line.
Exactly. Type 2 RPGN is immune complex mediated. This is what you'd see in severe cases of post-strep or lupus nephritis. The IF pattern is granular, reflecting those clumpy deposits. And type 3 RPGN is the pouchy immune type.
Pouchy meaning few.
Right. The IF shows few or no immune deposits. The inflammation is driven by small vessel vasculitis, and it's strongly associated with being ANCA positive.
Let's focus on type I for a second. You mentioned Goodpastures targets the alpha-3 chain of type 5 collagen. What's the clinical implication of that specific target?
That alpha-3 chain is essential for the GBM. But, and this is the profound clinical danger, that exact same antigen is also present in the basement membranes of the lung alveoli.
Ah, so that's why it's a pulmonary renal syndrome.
That's why. Goodpasture syndrome typically causes severe pulmonary hemorrhage coughing up blood alongside the rapidly progressing nephritis. It's a true medical emergency.
Okay, let's shift to the nephrotic syndrome, the leaky filter crisis. Here, the issue isn't so much inflammation, but the functional loss of the filter's selective power.
Right, we contrast this sharply with nephritic. The defining features here are massive proteinuria, which is losing more than 3.5 grams of protein a day.
Which leads to severe edema.
Severe generalized edema, starting around the eyes and then pitting in the legs, all driven by the loss of oncotic pressure. This, of course, means severe hypoalbuminemia, and then the body's compensatory responses kick in. Hyperlipidemia and lipiduria.
And the primary mechanism is the loss of that negative charge barrier we talked about.
Yes, letting that negatively charged albumin just pour through.
Okay, so let's look at the diseases that cause this, starting with the most common cause in children, the paradoxically named minimal change disease.
The name really speaks to the visual paradox. It's the most common nephrotic syndrome in kids, and it's defined by the fact that the light microscopy, LM, is essentially normal.
So a pathologist looking at it under low power might see nothing wrong.
Exactly. The injury is purely functional. You have to go to the higher resolution.
The EM.
Yes, the diagnosis rests entirely on the electron microscopy finding. widespread effacement of the podocyte foot processes. They basically smear or fuse together, destroying the slick diaphragm and, crucially, that negative charge barrier.
But the good news here is the clinical takeaway.
The good news is that it typically responds dramatically to steroids.
Okay, next, the most common nephrotic syndrome in adults, and one that signifies actual scarring and chronic damage, FSGS.
Focal segmental glomerulosclerosis. It's defined by scarring sclerosis. That is focal, meaning it only affects some glomeruli, and segmental, meaning it only affects parts of the affected glomeruli.
And on LM, you see those areas of segmental scarring.
You do. And clinically, FSGS is challenging because it can be primary or it can be secondary to some profound systemic stressors.
The source material links it
To infections like HIV, toxins like heroin use, and chronic damage from uncontrolled hypertension. We also know that some variants, especially the collapsing type, have the worst prognosis.
Now, for the disease that provides one of the most stunning pathological visuals, membranous nephropathy.
This is a classic autoimmune disease. The fundamental difference here is the location of the immune complex deposition. They deposit on the epithelial side of the GBM, just beneath the podocytes. As the kidney tries to wall off these deposits, it lays down new basement membrane material around them.
And that leads to the iconic look.
Precisely. On EM, you get the classic spike and dome appearance. The spikes are the new GBM material growing between the deposits, and the domes are the immune complexes themselves. On LM, you see a general thickening of the capillary walls, and IVE shows a granular pattern. It's an immediate, definitive diagnosis.
And finally, the tram tract disease.
That is MPGN, membranoproliferative GN. This one often straddles the line between nephritic and nephrotic. On LM, you see mesangial proliferation and, critically, GBM splitting. The capillary loops look like two parallel lines, the distinct tram track appearance.
And you can differentiate between types.
Briefly, yes. Type I is usually immune complex driven, while type 2, now called C3 glomerulopathy, is driven by complement system dysregulation.
It's so clear that the kidney is this canary in the coal mine for what's happening in the rest of the body.
It absolutely is.
So let's use the kidney as a barometer now and look at how these big systemic diseases manifest within the glomeruli, starting with the big one, diabetic nephropathy.
It's not just common. It's the leading cause of end-stage renal disease requiring dialysis, period. The whole thing is rooted in the chronic effects of hyperglycemia. The progression is textbook. It starts with early hyperfiltration, the kidney just working too hard.
And that leads to the first clinical sign, which is microalbuminuria.
Exactly. Small but detectable protein loss, which eventually becomes massive proteinuria and then total failure.
What are the pathological changes we see on light microscopy that really confirm advanced diabetic damage?
There are three critical LM hallmarks. First, the most famous and pathognomonic finding, the Kimstein-Wilson nodules. These are large, pink, spherical masses of mesangial matrix in the center of the glomerulus.
A structural proof of damage.
Yes. Second, you see generalized GBM thickening. And third, and this is crucial, you see severe arteriolar hyalinosis, which is particularly bad in the efferent arterioles, the ones leaving the glomerulus.
So it's that combination, the nodule, the thickened membrane, and the damaged efferent vessels that seals the diagnosis.
It really is.
Next up, lupus nephritis.
Lupus. The poster child for systemic autoimmune attack. It's an inflammatory disease where the body produces autoantibodies against its own nuclear components, and the resulting immune complexes just deposit everywhere, with the kidney being a primary target.
And you mentioned a spectacular IF finding specific to lupus, the full house IF. What makes that so unique?
It's the sheer volume and diversity of the deposits. When you do the immunofluorescence, you find deposits of almost everything: IgA, IgM, C3, and C1q. This full house tells you the immune system is just bombarding the kidney with everything it's got. It's a definitive stamp of lupus activity.
And the classification system reflects how severe that bombardment can be.
Exactly. Lupus nephritis is classified from I to CPAS based on the location and extent of the damage. We have to stress that class 4, the diffuse proliferative type, is the most common severe form and carries the highest risk of progression to ESRD if you don't treat it aggressively.
Let's talk about blood pressure. Hypertensive nephrosclerosis. It's basically hydraulic trauma to the fine vessels of the kidney, right?
That's a great way to think about it. We look at it as the slow burn versus the acute explosion. Benign hypertensive nephrosclerosis is from years of moderate, poorly controlled hypertension. The pressure causes plasma proteins to leak into the vessel walls, leading to hyaline arteriolosclerosis.
A slow, chronic, ischemic process.
Right. but when the blood pressure spikes rapidly and severely in a medical emergency.
You get malignant hypertensive nephrosclerosis.
And that results in acute endothelial injury and this aggressive concentric proliferation of smooth muscle cells in the vessel walls. Pathologically, it creates the defining image, the onion skin appearance, or hyperplastic arteriolosclerosis. It's a classic signal of a hypertensive emergency.
Okay, moving to a disease of protein misfolding, amyloidosis. What visual and chemical clues does the kidney give us here?
Grossly, a kidney with severe amyloidosis is classically described as enlarged and waxy. The amyloid protein deposits in the mesangium and GBM, but the diagnostic proof is entirely chemical and optical.
The Congo red stain.
Exactly. You use the specialized Congo red stain, and when you view that stained tissue under polarized light, it produces this breathtaking, unmistakable visual, apple green birefringence. That green glow is the definitive marker.
Let's cover a couple of infectious and immune defect markers. How do we distinguish the scarring of chronic pyelonephritis from, say, vascular disease?
The key is the cause and the resulting pattern. Chronic pyelonephritis comes from repeated ascending UTIs, often because of an anatomical problem like vesicretal reflux, VUR, or an obstruction. Because the inflammation is patchy, the scarring is also visually distinct. It creates coarse, asymmetric corticomedullary scars.
Unlike the fine, symmetrical scars from something like hypertension.
Exactly.
And what about that rare defect in macrophage function?
That would be malakoplakia. This is a condition where large macrophages infiltrate tissues, usually in the urinary tract, and form these yellow plaques. It's linked to a failure of these macrophages to effectively digest bacteria, often E. coli. The key microscopic feature is the presence of Michaelis-Guttman bodies, these calcified inclusions inside the macrophages.
We're concluding our pathology survey now with the major mass lesions of the kidney, shifting from inflammation and systemic failure to abnormal cell growth.
Right, tumors.
Starting with renal cell carcinoma, RCC.
RCC is the most common kidney cancer in adults, and understanding its cell of origin is vital. The most prevalent subtype, the clear cell type, originates specifically from the proximal tubular epithelium.
And they get that clear look from accumulating lipids and carbohydrates?
That's right.
What are the major risk factors here?
They're largely environmental and genetic. Lifestyle factors include heavy smoking, obesity, and chronic hypertension. Genetically, there's a really strong association with mutations in the VHL gene, which is von Hippel-Lindau disease.
Now, clinically, there's that famous triad of symptoms: hematuria, palpable mass, and flank pain. But the source material offers a crucial piece of clinical perspective on this.
This is an essential clinical pearl. While that classic triad hematuria, flank pain, and a palpable mass is what everyone learns,
It's not what you see.
the reality is that only about 10% of patients present with all three symptoms at the same time. This fact really highlights why most RCCs today are found incidentally on a CT or ultrasound. For some other reason, it totally changes your clinical approach.
Shifting to pediatric cancer, the major one is Wilms tumor. What defines its unique histology?
Wilms tumor, or nephroblastoma, is a complex embryonic cancer defined by its characteristic triphasic pattern.
Meaning it has 3 different components.
Right. Microscopically, you see 3 things that represent early kidney development. Blastema, which are these sheets of small blue cells, stromal components like muscle and connective tissue, and epithelial components like primitive tubules. And it's strongly linked to congenital syndromes, especially Weill syndrome and Beckwith-Wiedemann syndrome.
And we should also mention the key benign tumors to avoid overtreatment.
Absolutely. First is the oncocytoma. It's benign, but it can present as a large mass, so it can be scary on imaging. Pathologically, you identify it by its large, pink, eosinophilic cells, which are just characteristically packed with mitochondria.
And finally, the tumor whose name describes its contents.
The angiomyolipoma, AML. The name tells you everything. Angio for vessels, myo for smooth muscle, and lipoma for fat. The presence of macroscopic fat is often diagnostic on imaging, and the critical clinical association is its link to tuberous sclerosis. Finding an AML, especially if there are multiple, mandates a full workup for that.
This has been a true masterclass in renal pathology, really guided by Dr. Kumaran's structured approach. We've distilled the critical markers from the microscopic scale all the way up.
We really have. We've established that visual vocabulary that makes the field understandable. You just have to remember the high-yield markers. The granular muddy brown cast for ATN, the geometric proof of the spike and dome pattern, the dire warning of the onion skin arteries, and that basket weave collagen of Alport syndrome.
By systematically connecting the three tools of diagnosis LM, IF, and EM to the clinical syndromes, we've basically provided a structured key to the entire field of nephrology.
It links a simple urine finding to the deep, invisible cause of a disease, whether that's a genetic mutation, chronic high blood pressure, or a systemic disaster like lupus.
And this structural deep dive provides a perfect contrast to the next area of urology signaled in our sources. The shift from this systemic kidney disease to highly localized, often acute pathologies.
Like testis and scrotal disorders, urethral injuries, penile fractures, a completely different world.
That distinction gives us a fascinating final thought for you to explore. We spent this entire deep dive discussing how systemic failure antibodies, metabolic chaos, vascular pressure is reflected in diffuse microscopic pathology.
Where the diagnosis requires probing internal system.
Right. But how fundamentally does that diagnostic path change when the issue is acute, external, and localized, like a testicular torsion or a penile fracture?
It's a great question. I mean, consider this. When the pathology is systemic, we're chasing antibodies, proteins, complement factors. When it's localized and traumatic, the diagnosis relies almost entirely on physical exam, imaging, and immediate surgical exploration.
So, how does the body compartment's systemic internal organs versus localized structural trauma dictate the sheer difference in the diagnostic toolkit and the speed of intervention?
That's a really interesting thing to think about.
We encourage you to reflect on that relationship between the systemic chronic pathology we covered today and the acute localized pathology that might be explored in future guides. Thank you for joining us for this intensive masterclass.
Until next time.